Hi, David. Welcome to the TNF panel. It's you and I this evening to talk. Can you tell us who you are and your Twitter handle?
Yes, David Liew from Melbourne, Australia, and you can get me at Dr. David Liew, Dr. David Liew. Yeah, good to be back and chatting TNF inhibitors with you, Janet.
Yeah, well, it's been an interesting day, although there was an awful lot of diseases discussed, which is the beauty of the ACR. We can learn so much. But have you got a TNF highlight for today?
Yeah, and I know we'll get on to oral surveillance eventually, but I think a abstract which was a little bit neglected, but I think was important, was data from Corevitas, what used to be known as the Corona Registry, and so looking at real world US data, in this case in rheumatoid arthritis patients, and it looked at TNF inhibitors versus IL-6 inhibitors, and particularly at monotherapy. It did look at combo as well, but I'm interested in the monotherapy bit because we've seen randomized controlled trials, ADACTA looking at tocilizumab versus TNF inhibitors. We've seen Monarch looking at sarilumab and TNF inhibitors, and both have shown that there's an advantage if you're not on methotrexate to go with the IL-6 inhibitor versus a TNF inhibitor. And I think that's always been a bit of a key point for IL-6 inhibitors. But does that actually wash out in real world practice? Because real world practice, as we know, is often quite different to how things look in trials. And so, in fact, if you look at this Corevitas data, things were basically the same between TNF inhibitor monotherapy and IL-6 inhibitor monotherapy. Nothing to pick between the two of them. From memory, low disease activity was at an adjusted odds ratio of 0.99. So really, I think perhaps sometimes there's a little bit too much made of the differences between our drugs. We fundamentally got a lot of good drugs, and I don't think that even if you can't take methotrexate, that you should veer away from a TNF inhibitor.
Well, I think that that's really interesting because it does go against, as you say, against the clinical wisdom. Um, I thought what was interesting were really this is an indirect kudos to TNF inhibitors and how they perform with respect to COVID. So there were actually two abstracts. So one was earlier on, abstract 87, really from some global registries looking at inflammatory arthritis, but also Crohn's, psoriasis, et cetera, but mostly IA made up the data. And then one that Professor Choi presented today on behalf of his group looking at the NHS in Wales, and that was abstract 990. And both of them, although the purpose of them wasn't exactly, they wanted to look at COVID outcomes and how patients did and how shielding sort of made less COVID infection occur in our IA patients in Wales. But both those two abstracts actually showed that, if anything, patients on a TNF inhibitor not only did as well as their peers, in general, they did better. And maybe there's something to it. So it's just something to keep in mind that we are worried about drugs like rituximab, but the TNFs seem to fare well. These are non-randomized, but they're consistent study amongst study. So I think that's a highlight for TNF inhibitors and a good safety message for our patients. So if we shift gears and talk a little bit about oral surveillance, I'd like to kind of think your take on what we've learned, not about a JAK or tofacitinib in particular, and the higher dose in particular. I think I'd like to ask you more, what would our take home of a study like this be on these serious adverse events, MACE, malignancy, VTE, serious infection? What is your take home on a TNF inhibitor? The patients were on mostly etanercept and rest of the world, but in North America, adalimumab. So we really had two comparisons, although they were put together. But what would you be able to tell your patient who's on a TNF inhibitor when they're asking about safety from these data that we just heard about today?
Janet, it's really interesting. I think that I've never heard more about the cardioprotective effects of TNF inhibitors than I have in the last couple of days. And I think that's obviously absolutely reasonable. And these aren't assertions, they're truths. But I think in a world where we're actually often worried about the underlying cardiovascular effect of rheumatoid arthritis, TNF inhibitors make a compelling prospect in terms of long-term therapy and dealing with it. I think if we can't say on one hand we know that rheumatoid arthritis affects the heart, We know that it's a cardiovascular risk. We know that, we should be considered like a cardiovascular risk factor like diabetes. We can't say all of that on one hand. And then on the other hand, say, well, we don't really care about cardiovascular risk and rheumatoid arthritis. Choose whatever drug you want. I think that's kind of from that point of view, and far be it for me to say that TNF inhibitors don't have their own safety issues of their own. But as far as cardiovascular risk is concerned, and I think once you start to add on the actual extra cardiovascular risk of patient, which the most of our patients have, then I think this has been really exciting data for TNF inhibitors. I just want to remind everyone as well that if you look at it's not like there's an efficacy difference between these two drugs. That between the two arms, you look at the efficacy data from oral surveillance, and it's exactly the same across the course of time. So, I mean, that's been my take on it, Jana. I mean, I'd be interested to hear what you think about what this means for TNF inhibitors.
Right. So, I mean, there's probably three possibilities. So one's cardioprotective and the other isn't, or one's cardioprotective and the other is even cardio negative, or they're both cardioprotective, but one's more so, or they're both cardio negative, but one's more so. So it's really tough to tell. And when cardiologists, having discussed the data in our journal club and things like that, even though, of course, the paper's not out yet on oral surveillance, but lots of press release data has been out. Some of the cardiologists say, well, you know what, the rate of cardiovascular events was very low in both groups. They said, if this is a high risk cardiovascular group, which obviously was event driven and it's randomized, so it's equal in the three groups, I would think you're confounding variables that are known and unknown. But they said, the rate's pretty low. So you're probably doing an okay job, even though you should try to get smoking cessation, on trying to actually control their blood pressure, their cholesterol, and that a drug, the incremental benefit or causation, as you might interpret it one way or the other, depending on the drug class, is probably far less important than, controlling the major risk factors. So I think you're right to say that we can rest assured for our patients, other than there is this warning about, severe congestive heart failure, TNF inhibitors shouldn't be used. But I think I do have patients in my practice where I forget that their ventricular function, LV function, is so decreased because they're on 4 drugs that keep them out of heart failure. They're on an ACE, maybe they're on a spironolactone, et cetera, low dose beta blocker. So I think overall, though, it's good news for those on a TNF inhibitor. I can't tell you to contextualize whether it's indifferent versus bad news for those on a JAK. Right now, it seems like it's bad news, but I think we'll contextualize it over time and look at the rates, looking at the INTRACT trial that was tocilizumab versus etanercept with or without methotrexate. This was all with methotrexate. The hazard ratios were almost similar. They were almost the same of tocilizumab compared to TNF. So again, numerically higher on tocilizumab, but met that non-inferiority. But the actual event rate it was still low, but it was higher on INTRACT. But 10 years ago, maybe we didn't have as many co-meds like lipid lowering drugs and things like that. So I think we'll probably see a lot of reviews, a lot of editorials, letters to the editor that will help contextualize. But I agree, this has been a good day for TNFs on the things that we've discussed.
Well, I think, all drugs allow good days as well, right?
That's right. Absolutely. But it's good. It's, as you said the other day, it's our old friend. We know it well, and we continue to use them. And I think we can improve durability and look at risk factors. We're already, having very little TB because we screen for it. Serious infection, we sort of know what to do if a patient's looking like they're sick, or we avoid it in the worst case scenarios of multiple serious infections of a lot of our advanced therapies. So I think we're learning a lot on how to treat our patients and their comorbidities and multimorbidities effectively. And TNFs are helping us learn some of that.
Oh, I mean, I think it'll be interesting as well, because we will have some real world data as well to look at. And maybe people do behave a little bit better when they know they're in a clinical trial. And maybe that is important when it comes down to cardiovascular risk. Maybe that's why the event rates are low. we've had enough experience with tofacitinib and with all the JAK inhibitors well, we have enough globally to be able to start to look at these data and to start to try and draw some conclusions. So I'm sure this hasn't kind of run its course, and it's interesting that I think when it comes to oral surveillance and the malignancy component, looking at what the real world data show versus what the trial shows may well be a little bit different. So let's see. I mean, I think let's see similar kind of things wash out with cardiovascular risk.
We will wait and see. So always a pleasure talking to you, and everyone, please continue to follow us at Room Now. Thank you.